you so much for attending. We'll wait a few minutes to give people an opportunity to join. We'll give the attendees, hopefully we get a good group. Welcome everyone to our webinar today. What we have and we decided to do today was to highlight a wonderful meeting that just occurred in Italy, orchestrated by, and the meeting was called CP360. And we wanted to bring on some of the organizers and some of the attendees to discuss what could be something that could revolutionize cerebral palsy and early detection of motor delay in infants at risk for cerebral palsy. We have 4 presenters, panelists today. I'll go ahead and introduce them one by one, and then they'll begin to present in order. And after they present, we'll open it up for discussions. Please remember to put your questions in the Q&A while they're talking. Or you can also put it in the chat. Our moderator today will be Dr. Mendonça, who will then moderate the Q&A session after. So our first speaker will be John Coughlin. Sorry, John, if I messed up on that. Coughlin, he is the Secretary General of the International Cerebral Palsy Society, and he's bringing together CP associations from over 60 countries around the world. And he is representing also a parent of a teenager with severe cerebral palsy. John represents and was one of the organizers of the CP360 Summit. We're also going to hear from Dr. Laura Prosser, who happened to also have presented in a seminar in August on what the University of Pennsylvania and CHOP was doing in this particular area of early detection. Dr. Prosser attended the CP360. She's an associate professor of pediatrics at University of Pennsylvania and at the Children's Hospital of Philadelphia. Dr. Prosser, is a physical therapist by training as well as a scientist, and she focuses on the development and rehabilitation of impaired movement in children and infants with CP. I'm also wanting to introduce Dr. Maura Casadillo. She is an associate professor of biomedical engineering at the University of Genoa in Italy, and she's affiliated researcher at the Italian Institute of Technology. Her research focuses on neural control of movement, human-machine interfaces, and rehabilitation engineering. Dr. Casadillo is going to bring us the engineering perspective. And then we have Dr. Deirdre Murray, who is MD, PhD. She's a professor of pediatrics and consultant pediatrician in the Department of Pediatric and Child Health. She's at Cork University Hospital, and that's in Ireland. And she does large international studies where she develops new ways to predict newborn brain injury. So we've assembled a wonderful cast today, and I will begin by asking John to go ahead and share his presentation. Please remember to put your Q&A put your questions in the Q&A as well as in the chat, and so that we can monitor it. So when we have that session, we can begin. Thank you, John, and go ahead and begin. I'll if anyone who's not speaking can turn off their video so that they can focus, the audience can focus on the speaker. That'd be great.
Quickly, sorry, John, before you start speaking, if you could optimize your presentation for screen view. The audience is currently seeing a big chunk of your slides that are blocked out.
Is that better?
We're still seeing the blocked out portion kind of on the side, so looks like there was something that was blocking your
Yeah. It looks fine to me, which is the problem. I can't work out what it is. Just a moment. You go back. So share some optimized video clip.
And try and share again. Yeah. Okay, that's better. We're still seeing the blocked out portion. Not sure why. It's like the lower
The lower right side of the screen, John, is that where the audience?
No, I've
No.
completely minimized the audience, and I've got it in the top right-hand corner where it shouldn't be interfering with anything.
There's usually an
Strange.
option at the top bar on your share screen that indicates like to minimize while sharing. I forget the exact words. That's usually when that's selected that gets rid of all of these blocks.
For those who are waiting, forgive our technical difficulties. We'll get started soon. You can try again, John. It's still there, but maybe there is a way to go ahead and just present or present from the part of the slide where it's taking up less portion on your screen. For whatever reason, that it's still blocked on the lower part. But let's go ahead for the sake of time, unless there's some.
Sorry about that, and I
That's
really
okay.
can't see from my end what the problem is. But thank you for the introduction, and the slides are a prop rather than containing key details, so I think we'll manage. Yeah, thank you for the introduction. As I said, my name is John Coughlin, Secretary General ICPS. Also the parent of a child with CP, who you see in the picture there at the Paralympics in Paris a couple of weeks ago. What is CP360 to start with? It's a collaborative initiative. It brings together the three founding members or the International Cerebral Palsy Society, which I represent, Cerebral Palsy Alliance in Australia, and Cerebral Palsy Foundation in the United States. But we also have other organizations becoming more involved, and indeed a network of people working in the research field, in practice, and representing the perspective that I bring, which is out of families trying to work together on this initiative, which is to really promote early detection of CP in order to intervene earlier. And we'll talk a little bit about that in a moment. ICPS, as Michelle said in the introduction, is an organization with member organizations in over 60 countries around the world. They are basically organizations that were set up normally by families to advocate for their children with CP. And you see today that they're mainly persons with CP themselves, and more in leadership roles, their family members, and indeed the frontline professionals who work with them. So why does early detection of cerebral palsy matter? Early detection allows early intervention, and the overall aim, of course, is that improves outcomes in the long term. But when we look at early detection, we have a problem. Half of children with CP spend time in a neonatal intensive care unit, so we know that they are high risk. So surveillance of their development is possible. But half of children with CP don't spend any time in the NICU. They're considered low risk. They're sent home without being followed up. And that means that maybe markers for developmental delay are being picked up too late, and that leads to late diagnosis. So it makes early detection all the more difficult. And my job really at the beginning of the meeting we had last week in Pisa was to bring the parent perspective. And we spoke to a number of parents from different parts of the world. And we asked them why in their particular case was their child CP detected late. What difference did it make that their child's CP was detected late? And why is it important from their perspective to detect CP earlier? And we received quite a range of answers to those questions. I want to share one of those video testimonies with you. This is from Joyce in Ghana.
Hi, I'm Joyce from Ghana, a health professional. I have an 8-year-old girl with CP. I realized my child had developmental challenges at about 6 months, and I decided to seek for help. I was told because she's a first twin, it's normal and that she'll walk and she'll be okay. I continued seeking for help when things were not improving, and I even went to a psychiatrist concerning the milestone, and I was told that we mothers are anxious when our children are not able to go through the developmental milestones, but we have to relax because with time they will pick up. This continued until she was about 3 years when I went to another health facility and she was asked to start physiotherapy. We were still not given a definite diagnosis concerning her condition. And this continued till she was about 5 years when she had a fracture. We were referred to a teaching hospital in Accra, and this fracture was not managed well because of her condition. And a pediatrician had to come to review, and she was told she has CP. This delay in detecting her condition has affected herself, we the guardians, and the whole family. Thank you.
So Joyce's story is pretty shocking, that it took so many years for her CP to be diagnosed. But it's not only a reality in low-income countries such as Ghana, it's also very similar to the experience that we had. We didn't take so long to get a diagnosis, but our child was born under difficult circumstances, not particularly prematurely at 37 years, but it was an emergency cesarean. He spent nearly 3 weeks in the NICU, but was let to go home and wasn't followed up in any particular way. When developmental markers started to be noticed that things weren't going as they should be, then we consulted a neurologist for about 4 months. He said, he's just a bit tense, wait and see. And then it wasn't until we saw a physiotherapist when he was 7 months that she said, no, something's not quite right here. And then we started going back to the doctors and so forth. And it wasn't then until he was 14 months that we actually had a proper diagnosis. And all of that is critical because it's in these first 2 years of a child's life when the brain is still in development and when an intervention could really make a difference in the long term. If you think about today and how important it is for him today to have physiotherapy several times a week and how he asks for it because he feels the need for it, and to think for all those months during that critical period he wasn't gaining access to those kinds of interventions, then it's really something we have to do about in the future. So basically these issues keep coming up in terms of the other testimonies which we were able to share. Even high-risk infants are not followed up adequately. Low-risk infants really stand very little chance of early detection. There's this problem among many medical practitioners of a wait-and-see approach when early intervention would be beneficial. Another issue is, of course, that it's actually difficult to diagnose with neuroimaging, that MRI scans are expensive, they're maybe scarce in terms of resources, and often frontline health professionals don't have the training and expertise to notice the signs of a condition such as CP or other developmental disabilities. And then one of the other things that Joyce picked up on in particular was how it affects and impacts on the family and caregivers and their mental health and their ability to cope going forward. Being well informed early is a way to ensure that they're well equipped to deal with the challenges. So that's where we come from, and the conclusion that if we could achieve in a cost-effective way universal screening of all infants for cerebral palsy and other developmental disabilities, that this would really overcome these barriers to early detection. And that's the background to where we're coming from with the meeting in Pisa last week. Thank you very much for your attention, and I'm going to hand over to the rest of the panel.
Thank you, John. Laura, if you can share your screen, John can stop sharing his, and we'll hear from Dr. Prosser, who will give us her perspective as a therapist attendee at the CP360 conference. Dr. Prosser.
Okay. There we go. All right, thanks, John, both for that introduction and again for hosting a great coming together of thought on this topic last week. So my role today is to share my perspective and reflections from the meeting from a physical therapy perspective. And as John gave some of an intro in his couple of slides just a few minutes ago, I wanted to underscore the fact that cerebral palsy is the most common cause of physical disability in children worldwide, and it is a permanent disorder of the development of movement and posture. I think traditionally we think of cerebral palsy as a physical disability, but more in older children. And I emphasize this part of the definition, the consensus definition, that is, it is caused by a problem in the development of movement and posture. And so if we really want to make long-term change, we really have to focus on when movement and posture are developing. And so the first 2 years of life are a critical period for the development of motor control. We know this from clinical studies in humans, and we know this from basic science studies in many species that translate to humans. So we can see this when we look at the gross motor development trajectories in children who have cerebral palsy. So here what you're looking at are gross motor development curves. Think of height and weight curves, but instead of height or weight, on the y-axis is gross motor development. And the 5 trajectories shown here are different severity levels of children with cerebral palsy from birth to 15 years of age. And we know that these levels, these severity levels, are quite stable after the age of 2. But before the age of 2, it is difficult to determine the severity level of cerebral palsy. And in fact, it often changes. One study suggested that it changes in almost half of the participants, of the children that they followed. And so what happens in the first 2 years of life really matters. And you can see sort of how close these trajectories are in the first 2 years of life. And so what we do, if we can make even small changes in the first year or second year of life, those could have significant impact on the lifelong trajectory of physical function. We also know that early motor experiences can improve outcomes, and we have guidance now on what early intervention for children between 0 to 2 years should look like. But this review was led, you can see this international author line here. So this was a large systematic review at developing these international clinical practice guidelines led by Kathy Morgan, who was one of the organizers of the summit last week. However, as a physical therapist, these recommendations still feel pretty general and pretty vague, and they are not specific enough, as some of our rehabilitation therapy guidelines for children at older ages. So in older ages, we have recommendations based on the GMFCS severity level, based on whether cerebral palsy is affecting the child more unilaterally or bilaterally. Here are recommendations for 0 to 2. I really think are just a starting point for what it should look like. I would like to see these recommendations be more specific in infancy and in early the early toddler years, so that we can be giving really an optimized therapy plan to each individual child. And so the idea is that we might have 3 babies with the same medical history, the same current status, but so these current tools of reviewing medical history, at measuring current status, do not give us a good prediction of the future development of motor control. And we often in our clinics, we see these 3 different categories of children. We see a child who perhaps has had a brain injury, perhaps was born preterm, had a significant neonatal medical needs. They may have normal motor control, may develop motor control normally and have typical milestones. This is a child who would not need intervention of any kind in terms of physical rehabilitation. A second child might have the same brain injury, the same medical history and current status, but this is a child who has delayed milestones, or will have delayed milestones, but they will develop their motor control normally. And for this child, we should be recommending short-term rehabilitation services and parent education to facilitate the achievement of motor milestones. And then we have children, a third child who might have delayed milestones in the future and have impaired motor control. This is what we would typically think of as cerebral palsy. And it's for these children who will have lifelong physical disability and lifelong rehabilitation needs. And so our decisions in the early months of life, we should be able to distinguish these 3 different trajectories for children so that we can most appropriately allocate medical and rehabilitation services. So our current tools have limitations. They lack automation. They require access to a local clinic or hospital with very highly trained medical or clinical personnel. And we're not able to distinguish between different types of motor control impairment in the early months of life. That might help us guide treatments and classify children beyond CP or not, but into different treatment pathways. And so there's great potential of early intervention to screen for cerebral palsy. So sort of my takeaways from the meeting is that we have this very easy to collect non-invasive video data. That is really the source data for this effort. Our modern pose estimation software from single camera video is sufficiently good for automated assessment, and it is rapidly improving. So we can identify children at this stage who should be moved onto a high risk for CP diagnostic pipeline. And we have guidelines for what that high risk diagnostic pathway should look like. I think that there's potential to, if we can do universal screening, then we can facilitate more clinical trials and early intervention across the world. And we desperately need this type of evidence to figure out how best to structure and deliver early intervention services, which won't be the same in every region and every country. And then finally, the potential of AI to guide treatment. So beyond this child has cerebral palsy, yes or no, or likely to have cerebral palsy, yes or no, and they should go into the high risk for CP pathway. But what can we be doing in the meantime with that 3 to 4 month old child in early intervention services that is optimizing how this child's brain can learn to move their body? So we have challenges, of course. the evaluation needs to happen at 3 to 4 months of age versus traditional screening systems, which are set up at the newborn age. We need to use videos, and so there are a host of privacy and security concerns, both from a caregiver family perspective, and also a regulatory, international regulatory perspective. And then once we are able to do the screening, there is great variation in country, regional, and institutional diagnostic pipelines. And so even if we identify the children that should continue, there's much work to be done then in making sure those children are able to be followed through the diagnostic pipeline and then into early intervention services if warranted. But despite those challenges, again, I'll bring us back to to remember that this is the most common cause of physical disability in children worldwide. And so it warrants our attention and our efforts to solve the challenges ahead.
Thank you, Dr. Prosser. That was very comprehensive and lots of food for thought. So what I'd like to do then is to have Dr. Casadillo talk from her perspective as an engineer about her takeaways from the conference. Laura?
And it's perfect to speak after Laura because she already made the first point, that for us that are engineer technician is important, that this field is a field in which we feel that we can make a difference. We can, providing the right technology and the right technological solution, we can really help doctors to find infant at risk. And so having an early detection and then having a timely intervention. So this is a great motivation for their work. And the meeting in Pisa highlights points that are really positive. So there is a lot of technical work and the results are promising. But also we were able to identify points in which we have to discuss with the clinician, we have to discuss among us for finding the best solution. And I prepare quickly some slides, so I will try to share my screen too, for highlighting to you these technical points. So first of all, let's see if I can share it.
Should be able to.
Share. Can you see it? No.
Yes, we can. Go ahead.
So the first good things, Laura already said that is the fact that the technology and the technology for the acquisition of the motion improved tremendously. From what was the state of the art, really now we can use a camera, normal camera, that allow us to, that allow us to record from our phone, our computer, and the fact that with this camera we can reach high quality, high frequency, so we can have really good images and good video, enable the fact that then we can do a good analysis and build good tools to support the doctor work. And these systems are not expensive, they are not cumbersome, and they can work in the hospital, they can work at home. Parents can use them, so they are easy to use, and the procedure can become full automatic. So the starting point is really the possibility to use video. But already on the video use, there are points in which, as technician, we can think and discuss with the clinician if really one single video from one single camera is enough, or for example, for recording more fine movement, as this one that you can see me doing. We need maybe 2 cameras, maybe they can be better, or we need a depth camera, But as Laura already says, already from one simple camera, we can really get a lot of useful information that can really help on the final classification and identification of infant at risk. And here, let me move this. And here you can see like a summarization of the pipeline that we work on. The first point is the video acquisition that I just mentioned, that in general can be done with a single camera. And this often, at the starting point, we have this, and we have this expert video or expert infant evaluation that evaluate the motion of the infants. And another important data that we need as a technician is the ground truth provided by the clinician. So a precise definition when we have the video to work on of based on what we define that the video is a video of an infant that has a specific motor disorder, or in this case, CP. This is all the technical pipeline. I said, so we have the video, and then how we extract the information from the video. So the two most discussed methods, let me see if I can go back so I showed that to you, were two. One that you saw already you saw the skeleton, but the principle is the same on the lower slide, in which we detect key point, point of interest on the image. And the other instead is like a pixelization of the image so that we analyze the silhouette of the infant. So these are two methods that can be used separately or combined. They work well, but we need also in this working, we need a consensus on how we find this point reliable, how many points we need to extract. So there is a need of a standardization to get reliable result, also on how we directly extract the information from the video. And then, sorry. I want to go back to my pipeline, sorry. And then when these information are extracted from the point, from the skeleton, or from the silhouette, or from both of these, we can do some processing and then obtain the parameters, parameters that describe how the kid is moving. These parameters can be general, like we look at the speed, we look at the smoothness of the motion, or can be really specific. So Laura was mentioning that one good point to look at the motion of the kids is 3 months. I hope that I understood it correctly. And at this time, we can really observe the crossing by the end of the foot of the infant of the midline. These can be meaningful parameters. Also here, we need to find what are the most meaningful parameters, how many we need, and so on. Also on that part, we had an important discussion that is still open. And on the parameters, on top of that, we build a classifier. We can have a different classifier that allow us to determine at the end if a new video is a video of an infant that is a risk. In this case, a risk to have a CP. And also in this case, there can be different classifier. And one important point that was discussed for a long time is the fact that for having this part performing well, we need a large amount of data. So one of the important point of the meeting was understanding how we can have a large amount of data and also agree on the quality of the video that have to be recorded for reaching a good classification. Of course, we can have also a parallel path. So the video acquisition can be directly used as input for the classifier. So technology, at this moment, this is the take-home message, is offering both from the hardware part, so low-cost camera with high potential, and both from the software part, the development of computer vision and machine learning algorithms allowed us to make really large progress in this year. And we hope to a close discussion, as was on that meeting, among technical people working on this work or in this field, together with all the clinicians and their experience, building on their experience to reach at the end methods that can be really automatically used and in the future in a universal way to detect infant at risk of neuromotor development, especially a kid with CP. And I hope that I was clear.
No, that was clear. Thank you, Mara. That was really good. And then we're going to finally hear from Dr. Deirdre Murray, who's going to give us her perspective as a medical faculty, an MD, who is a pediatrician. Go ahead.
Thanks so much. I'm just sharing my screen now.
Wait, so I think, Mara, you have to stop
Oh, yeah.
sharing.
I stop share.
Yeah, there we go.
Okay. Okay. Right. Can you see that?
Yes, we can.
Yeah. And you can hear me okay?
Yes, we can.
Yeah. Great. So thank you so much for asking me to speak, Michelle. And it was really fantastic to meet Michelle and Laura at the summit. We hadn't met before, but we had a lot to talk about. And hopefully we'll continue to collaborate as part of this consortium. So maybe just, I suppose, I know people have mentioned this already, but to start with the challenge that we're facing. This is, so CP is a global challenge. I'm from Cork in the south of Ireland, and we have begun to look at early detection in the high-risk children and set up a kind of a screening pathway for those children based on all the work that has been done by the CP Alliance in Australia and those fantastic international guidelines. But we know that even though we are getting better at picking up the high-risk babies, about 50% of children born with cerebral palsy won't fit into that group. So currently we use the cutoffs of a preterm infant born less than 32 weeks, or neonatal encephalopathy, or stroke. So birth asphyxia or stroke or some other, intracranial hemorrhage around the time of birth. But if a baby doesn't fit into those kind of predefined high risk categories, and 50% of children with CP don't, they will present much later on with motor disability when somebody notices, usually the parents, looking for, medical intervention. But often it takes, they have to be seen by an experienced neurologist or somebody who really knows what they're looking at, because CP in those low risk infants, the rate is about, 1 in 1,000 or 1.3 per 1,000. So your ordinary general practitioner might not see very many babies with that in their whole career, at an early time point. So that's why there is sometimes this diagnostic delay, unfortunately, which puts a lot of extra stress on the parents, as John so nicely articulated. And so by the time the CP is picked up, the babies are then beyond this window of the most neuroplasticity. And it's a global challenge. There's 18 million people around the world with cerebral palsy. So it's not just for Ireland. What we're really trying to do, the idea behind CP360 is to try and take that global view of the problem. And we know that the general movements assessment is really good. If you've got a highly trained GM assessor, who's been trained by one of the licensed tutors, and they've done the 4-day course and they know exactly what they're doing, they are able to use that skill to pick out babies who have abnormal movements and are at risk of CP. But to get that training, it's expensive. It costs over €1,000 to do the course. You have to go away, usually travel for 4 days. And I had a look at the GM Trust, are the group that run the training programs. They do a fantastic job, but if you look at their website, there's only 12 licensed tutors and 3 honorary tutors worldwide. So to try and get everybody trained up so that all of these babies that are born every year, the 130 million babies that are born every year, it's just not feasible. So there's not enough to meet the need, and it's not scalable for universal screening.
So of course, people have started to look at this, you know, and for the last number of years been looking at, can we automate this? It's a typical human response to a difficult challenge is, can we get a machine to do it? Can we automate it? And so many different groups have been looking at this challenge to see if they can automate. And we've heard already all the fantastic progress that's happened in that. So can AI help to provide universal screening? And the CP360 met in New York in May of 2023. And we were given the task of trying to come up with what are the main challenges to CP, improving outcome for children with CP. And one of them, the three main challenges that were picked was this trying to get universal screening. And sorry, now just get rid of that off my screen. Trying to develop a universal screening, and it was felt that the general movements assessment and automation of that was the most promising way of doing that. But at the moment, there's many groups in many different countries who are trying to develop this AI solution. A lot of them are working with small cohorts. They might use different criteria for, as Dr. Marsha described, that ground truth. So some people are trying to predict abnormal general movements. Some people are trying to predict the type of abnormal general movements, like absent fidgety, which is one of the classifications, or some people are trying to predict CP as the ground truth. So it's very hard to compare the algorithms to see which is the best algorithm and which is the one that we should bring forward as a universal screening. So a lot of people competing to solve the same problem. So what we thought at the meeting of CP360 is, why don't we try and get people together, get them talking to each other, and get them trying to find a way forward that we can all work together to come up with this universal screener. So in advance of the summit in Pisa, we sent around a survey from all the groups that were invited. So there's 15 groups from all over the world. And we asked them how many of them had general movement assessment videos that were available to share with others. And so 14 out of the 15 said they did have videos. We asked them how many videos, and they each gave different amounts. But actually, when we added them all up together, there was over 15,000 videos available to the group, which is an amazing amount. We asked them about the ethnicity of the children in the videos. And the importance of that is, we know that we can't have that, we can't have any ethnic or racial bias inbuilt in our AI algorithms. You know, there's no point in just developing it for one particular cohort. We want this to be a global universal solution. So many of the groups did have diverse ethnicity, but we weren't able to get down to the detail of how many, so what percentage of your children are from these different groups. So that's work that needs to be done. The majority of the group said that their cohorts were a combination of low and high risk infants. So it's hard to know, out of that 15,000, if they were all low risk, then there might, if we say, if you remember, the rate of CP is about 1.3 per thousand. So we might only have 20 babies with CP in that 15,000 low risk videos. Now, a lot of them will be high risk, and then in the high risk groups, it could be 10% have CP. So we really don't know yet how many of those videos are of children with abnormal general movements, how many have cerebral palsy, go on to have confirmed cerebral palsy versus non-cerebral palsy. And we know that a lot of babies will have abnormal, well, not a lot, but the proportion of babies who have abnormal general movements, only at a smaller proportion, about 10% of those will actually end up having CP. But we also know that the abnormal general movements might be a sign of some other developmental problem down the line. So there is some evidence that the general movements assessments could be used to predict other developmental delays, like cognitive disability or autism. So we don't know how many of those videos do we have outcome beyond CP, how many have a CP diagnosis and how many have other diagnoses. So there's still a lot of information that we need before we know how good our grouped database of videos will be to answer this question. And then the other questions that came up is, you know, what about the quality of the videos? So Alicia Spittle, who was one of the organizers of the group and is based in Australia, has developed this Baby Moves app, which they've used really successfully to get large amounts of videos from healthy, low-risk cohorts. And the parents are, you know, download this onto their phones. They're given very simple instructions. There's a clear outline of where the baby should be positioned. And they're given information about, you know, what clothes to have on the baby and all of that. So this will give nice, good quality videos. But of the, you know, the 15,000 videos that might be available to the group, we don't know yet what the quality of the videos will be, what the positioning will be, will the baby be clearly seen, what will the background be, if it's very dull, or, you know, does it make a difference whether there's a white sheet or a black sheet? Will it make a difference whether there's audio available so that we can hear whether the baby's crying, or is it, you know, some of the videos will have the facial blurring so that we mightn't see the expressions. And then the next question is, you know, how many of the group have ethics or consent, parental consent for sharing with other groups to solve this problem? Some of them might have, but we're going to have to get everybody to go back to their ethics now and look at, can they share the videos? And then how many have simple clinical data available, such as the gestational age, the age of the baby when the video was recorded, the sex of the baby, because it might not always be clear if they're not wearing a pink or a blue baby grow, and simple things like that that could also be used to add to the predictive ability of the model. But there are groups who are looking at this, at the ability, you know, as we've seen already, pseudo-anonymizing those videos by facial blurring and or changing the videos to the open pose, just stickmen. So we had a lot of discussion at the meeting about whether it's better to put the time and effort into anonymizing all the videos, or is it better to go and check which ones we have consent for and focus on getting good consent, or even going back and consenting those parents to ask them, can we share the videos? And we had to get legal advice on that, which John helped us with. So I've mentioned about clinical factors, and I think this is really important. We're beginning to look at now the other factors. So if you think about what we use for the high risk pathway at the moment is gestational age less than 32 weeks, or a history of hypoxic ischemic brain injury or neonatal encephalopathy. Those are just two, you know, very black and white binary variables. But there's lots of other risks that we know add to a baby's risk of cerebral palsy. So this is a study that was done in it was a Canadian Cerebral Palsy Registry, and then they compared all the children with CP. They compared their perinatal pregnancy data to a healthy birth cohort. They found that 12 clinical factors could help in the prediction of those babies, even in low-risk babies who didn't have encephalopathy, to see which ones went on to have CP. And there was 5 what they described as modifiable risk factors, and that was, you know, tobacco use by the mother, maternal drug use, chorioamnionitis when there's infection of the amniotic fluid during the pregnancy, maternal diabetes, or maternal preeclampsia. And if a baby had all 5 of those, then their probability of CP just went up and up and up. And so you could use that to predict. So I think that's also what we need to be doing, is looking at those clinical factors to add to the video information. And I think one of the things that we'll be doing in Cork is looking at doing a similar study, but looking at a Swedish pregnancy database where we'll be able to link that with the CP data from the babies. So not just focusing on a birth cohort, because the babies in a birth cohort tend to be different. The mums who enroll in a birth cohort and follow, you know, continue to stay in the birth cohort tend to be different to mums that don't go in. And we already know they have lower rates of smoking, of diabetes, of you know, drug and alcohol use. They're of higher socioeconomic background. So you don't want to be biased by just the fact of whether or not they were in a birth cohort. We need a population-based study to look at those clinical factors that then might be fed into your algorithm in addition to your clinical data, or in addition to your video data. So I think that's where we need to go next. We need to do a lot more work on trying to find out exactly the standard of the videos that we have and the type of data that's collected there, and then try. But I'm really hopeful that we have a fantastic group, and that we're going to be able to solve this problem. That's it for me.
That was excellent.
Sharing.
So we learned a lot, and I'm going to pass it on to Rochelle to lead out the Q&A session.
So thank you for this wonderful presentation. And we have a question from one of our participants about what type of rehab therapy do you recommend in the early years of a child with CP? And how do you use a video to make decisions about the type of rehab or rehab therapy?
Laura, I don't know if you want to answer that one.
Yes, yeah, I'll take that one. So these are great questions. We can start to answer that, and some of that answer to that question is not yet known. So right now, the current guidelines for early intervention for infants who are at high risk for cerebral palsy, these are published in JAMA Pediatrics. Kathy Morgan from Australia is the lead author. But to summarize, for gross motor development, the two key recommendations are that it starts early. Starting early is sort of the most important part. The content of it has two parts, so that it's task specific, meaning that the child is trying to do something in their environment that is a usual infant developmental task or milestone. And so reaching, sitting up, but something that is salient to the baby. And so, as much as it can be embedded in their natural environments, the better. And the second part of that is that there is some problem-solving aspect to that. And so the child is not having something done to them, but the child is trying to figure out or to sort of solve a motor problem. And so they're given time and patience to learn how their body is able to move, and how their body might be able to move with practice. And then one of the key recommendations, sort of to follow up, to go hand in hand with that, is against passive movement. And so there is not evidence for passive movement that is essentially moving the child's body for them, whether it's therapist directed or parent directed. But that does not teach that. That might move the child's body, in ways that seem to be typical, but that is not teaching the infant's brain to learn to move. And so really a task-specific problem-solving approach. Now, I would like our recommendations to be more specific than that for specific infants. And so if we can use this AI technology to predict which children will have unilateral versus bilateral cerebral palsy, or the severity of their cerebral palsy, then I think we will be in a great position to individually prescribe rehabilitation therapy protocols for specific children. We're years away from doing that. We need lots more clinical trials in that area. And the second part of that question was, how do we use a video to prescribe therapy?
Yes.
And so that's if the AI, this initial effort is screening for infants who are high risk for cerebral palsy. So it is a couple of steps down the line. The videos will be used to identify children who should move to a high risk for cerebral palsy pipeline. And if they are then diagnosed with cerebral palsy, there are certain treatments like the early intervention guidelines that I just referred to. But so we're not quite taking the step of video to treatment just yet, although I think the potential is there.
That's great. Thank you so much. Another question by one of our participants is, can AI be used to diagnose CP between 2 and 6 months of birth? Or, is that potential being explored with everything that you guys are doing?
Yeah, I mean that's maybe we weren't very clear about the time because we're all used to talking about general movements assessment, but that's the main focus has been on that sort of time point, from 8 to 20 weeks, where the general movements and looking at these kind of fidgety movements and when they're absent or there's abnormal movements that could predict. So that's the time point that we would use that in low risk infants, that they ideally, when we're finished this work, parents everywhere could have a baby moves app or a video app on their phone that they take a video of their baby. It gets sent up to the cloud. The AI analyzes it and puts them in a risk zone for CP that tells them, okay, you need to go and see a neurologist. Your baby needs to be referred to a pediatrician or a neurologist who can do a formal assessment then to get the diagnosis.
Right.
So that's the end game.
Yeah, that's perfect. That's what we're keeping our fingers crossed for.
Yeah.
So, another question, and this is moving slightly away from AI, but kind of related. So what is the current state of the use of robotics and the rehab of cerebral palsy?
That's probably a question for for Maura or Michelle.
Go ahead, Mara, you can answer. You're
Okay.
muted.
There are several technologies that are used, and as in general, for rehabilitation in the last years, we saw a growing of technology applied to the rehabilitation field. And so we can go from tools that are more diagnostic, like you can think about dolls that the kids can use, and they can be used to as the video, to predict, to support the diagnosis, to maybe the robotics device that you can think more easily as for rehabilitation, that can help the movement of the limb in encouraging certain motion or improving endurance and so on. So there are several attempts, and there is a lot of research in the field. So the technology also in this field we have several things available, both from the hardware and from the control point of view. The question that maybe I bring back this question to all the panelists, how effective they are, So this is not only the case of CP, In general, in rehabilitation, especially for 3 children, when you find this solution, you find that there can be tools that doctor can use, and the first answer is there are these tools, But I still feel, then we can see what is the opinion of Michelle, but I still feel that there is a limitation, that there was a moment in which we thought for the rehabilitation that they could have been a solution, of course, as tool in the hand of the therapist or the clinician. But now we see that they provide the fact that you can have more endurance in the exercise, not getting tired, provide more repeatability, and so on. But all the revolution that we were expecting from as a result at the end, we are still waiting for that. There is still something missing, and my personal opinion is sometimes that really what has been done, for example, with this meeting, has been missed in this process. So the technology developed, arrived to the clinician, arrived to the final user, and there was not at the beginning a co-design, and so for that reason, maybe there are still limitations. But this is my personal opinion, okay? The last part is my personal opinion. Technology is a
I think Laura actually may be able to answer this as well, but I know one of the things that we've been doing in collaboration with Laura's team at CHOP is kind of thinking about creating sensorized environments, not just for collecting video data, but also for eliciting movement patterns and maybe to elicit play as a way of doing therapy. I know that in Italy, there's the Care Toy group. So it also depends on the age of the baby. So there are groups that are developing mechatronic systems that could be utilized by babies during this critical young period. But I know Laura's group has been looking at CP for encouraging kids to develop improved gait using a robotic technology, and she's been getting some good results on that. So I would suggest that Laura could also comment, and these are a little bit older than infants. So I think we should qualify by the age group. So the really young infants, there are some technology out there that's still really in development spaces. For the a little bit older, I know Laura's been working on utilizing some for gait retraining, and then for older population, some of the adult systems possibly could be used with the older children with CP. But Laura, you want to weigh in on that?
Sure. Yeah, I'll be pretty brief, just in the interest of time. So we are doing some work with robotic devices to for crawling. So in infancy, actually, Michelle, and then also up through 18 months for walking. I think for the guidance for robotic use of robotics and interventions is it's really an area that we should explore, because we know that children with CP cannot create for themselves the same motor learning opportunities that typically developing children are able to create for themselves, whose motor practice is largely self-initiated, and they scaffold for themselves to be harder and harder motor skills throughout the day, weeks, months. And so the use of tools to encourage that is quite promising. I think they fall into two main categories. In the first couple of years of life, the robotic tools should not move the baby for them. The robotic tools should be designed to help the child learn to move for themselves in whatever way they have potential to do that. That is a much harder engineering problem rather than designing an exoskeleton that moves a child in a particular way, which has been done and is not effective as a simplification of that work. But those compensatory tools for older children, teens, and adults with CP also have great potential. And so using these robotic tools as compensatory or complements to function, I think there's great potential. So in the early months, we want to try to encourage the brain to learn to move from these devices, and in older years, there's great potential for these devices to improve function and participation in many aspects of life.
That is great. We actually have several more questions, and I know we're way over time. So I'm going to ask one more question, and then hopefully if the presenters can just look at the Q&A and see if you can answer things just via message. But one of the questions was, is there a way to carry out the pose estimation while eliciting some primitive reflexes like the Moro reflex or ATNR? Don't know if you had thoughts around that.
I don't think it's been tried. These are traditional reflexes that are part of a number of our assessments. The part of the Hammersmith assessment has some reflex testing in it. So I do not think it has been tried. This work is spontaneous, is recording video from spontaneous movement of infants. And well, this could be a whole conversation on its own. Sort of, what do the reflexes mean? Sometimes they seem to be transient. Sometimes they're persistent. It's hard to predict. But really, more important than the study of reflexes, I think the field is moving to, is the study of volitional movement. And so what the child is able to do volitionally probably is more important than the reflexes. There's some suggestion that reflexes sort of persist and fill the space when volitional motor control does not develop. So
That's great. And I know several of you have posed additional questions. So what we're going to do is we're going to compile the questions and send it to our panelists, and then reach out to the people who posed the questions and send you responses, just in the interest of time. And now people have other things scheduled. So we'd like to end by saying thank you so very much for this absolutely fantastic presentation today. And I think it ignited interest in a lot of people about potentially maybe attending, participating in some way in future things that happen. And I know that we would love to call you back at some point as you continue to work in this in a year maybe, to see where things have moved to, and what progress you're making, and what the community could help with. So thank you so very much for coming in today.
I do want to mention that the CP360 group are planning a position paper, so that might be something that we could post to the group once that comes out. Maybe about, I don't know, John, when that might come out, but we could definitely keep everyone posted.
Yeah, that will take some time to put together because there are obviously a lot of moving parts here. And in a way, the meeting last week was just starting a discussion about focusing on the different aspects and bringing together all of this research that's been done by these groups around the world, which is really great to be working together collaboratively, pooling knowledge, pooling data, and moving the field forward.
On that note, thank you so much for coming on. This is super educational, and I'm sure our audience appreciated the information. And hopefully, if anyone wants to reach out, we can provide the email, if you guys don't mind. We could provide the email of you guys to the panelists if they want to then reach out specifically, and either for collaboration or anything else, because I do know that we had a diversity of folks in Cameroon and different places in Africa who might want to collaborate. So we'll try and do that and provide that to those in attendance. In Botswana, someone said. All right, guys, thank you so much again, and really appreciate it. We'll save the chat, and then we'll distribute certificates via Elsevier. And if you do want to reach out to our panelists, if the panelists don't mind putting your information in the chats, and then that way anyone who wants your information can just grab it and reach out specifically.
Thanks, everybody.
Thank you.
Thanks.
you.
Bye.
Bye.
Thanks.
Bye.